Welcome to the Orthopedic Film Festival 2022, the first ever international film festival made for and by orthopedic and trauma surgeons. We want to take this opportunity to say a special thank to our chairs and pioneer partners Bauerfeind, Geistlich, Methis, Medi and TETEC, the innovative industry leaders supporting the realization of this flagship event.
Yeah, we have an international community here, and the first video comes actually from Warsaw, Poland, from our colleague Urszula Zdanowicz, which will be about the menisco-fibular ligament, a new topic, I think, in knee surgery, and we are very excited of the video. So let's start.
Injury to menisco-fibular ligament is not commonly recognized. The anatomy of lateral meniscus is complex and structure-function relationships are only partly understood. A true understanding of anatomic structure-function relationships is necessary for optimal surgical repair following injury. This ligament is a relatively unknown ligament, and there are only a few studies describing it. On the other hand, injuries to lateral meniscus at the level of hiatus popliteus are common, but also hard to handle. Results of suturing lateral meniscus in that area are not always good, and failing to save lateral meniscus will inevitably lead to early osteoarthrosis. This relatively large ligament is believed to stabilize the lateral meniscus and thus have a significant impact on biomechanics of lateral meniscus and play a role in lateral meniscal tears. The presence of meniscofibular ligament may biomechanically explain lateral meniscus longitudinal tears at the level of hiatus popliteus, while the knee moves from flexion to extension and the lateral meniscus moves anteriorly following the femoral condyles and being pulled by meniscofemoral ligaments. The meniscofibular ligament together with meniscopopliteal fascicles act to limit the movement. If the balance gets interrupted by external force, for example, meniscal injury can occur. Meniscofibular ligament is an inverted trapezoid-shaped structure with a mean width proximally of 13 mm and mean width distally of 8 mm and mean length of 19 mm. The proximal attachment began at the inferior edge of posterior part of lateral meniscus, at the level of the articular surface of lateral tibial condyle. The medial vertical edge of the ligament began at about the level where popliteus tendon crosses the lateral meniscus. However, its lateral edge could be distinguished from the coronary ligament only by observing its distal attachment, which means coronary ligament attached to the tibia, while meniscofibular ligament attached to fibula. Stated differently, the ligaments are confluent proximally and are separate distally. The distal attachment of the meniscofibular ligament of fibular head is deeper than the distal attachment of fibular collateral ligament. The meniscofibular ligament attaches just behind the cartilage margin of articular surface of fibular head at the proximal tibiofibular joint. In MRI, the ligament may be best visualized in sagittal PD sequence, especially if there is a contrast or hemarthrosis in the joint. In acute cases, local edema may be the only indicator of meniscofibular ligament injury. Radial plane images can facilitate visualization of meniscofibular ligament injury. For arthroscopic visualization of meniscofibular ligament, the best is to put the knee position in full extension and the camera is placed in the posterior lateral gutter of the knee joint, anteriorly to intra-articular part of popliteus tendon through superior lateral portal. The working portal is standard anterolateral portal. In this position, the meniscofibular ligament may be easily evaluated and treated. The meniscofibular ligament may be also visible from anterior beneath the lateral meniscus. This is the arthroscopic view of meniscofibular ligament while it's intact. This is the posterior lateral gutter of the right knee joint. You may easily see back of the lateral tibial condyle, popliteus tendon running below meniscopopliteal superior fascicles, and meniscofibular ligament itself. And here is how it looks like when it's injured. Left knee joint, same location. Chronic injury marked with an arrow. And here's an acute injury with fresh hematoma there. Suturing of this ligament is best performed with small pigtail device, or when you suture the lateral meniscus in the area of hiatus popliteus from the anterior, make sure you reattach this ligament to the lateral meniscus. The meniscofibular ligament is a rarely discussed anatomic structure that is important for stabilization of lateral meniscus. Further anatomical and biomechanical studies are needed to fully evaluate its clinical importance. In cases of chronic posterior lateral pain syndrome, it may be helpful to evaluate posterior lateral corner structures as well as the meniscofibular ligament as a possible cause of pain and instability. The reconstruction of this ligament during lateral meniscus allograft implantation must be also considered. Thank you.
Yeah, good evening, Ursula, and thank you very much for this really great video. So you presented us some really nice anatomy, and your video looked very much professional. So my first question would be, do you have like a professional production team behind you, or do you do that all by yourself?
Now, from the background noise at the very beginning, you can see I did it myself. So.
Okay, great. Then you are talented in doing that. We may all learn from you. Now, from the medical point of view, how often do you see patients presenting with a lesion of the meniscofibular ligament?
Much more often than I'm used to. I can ask you differently the same question. How often do you see lateral meniscus injured at the level of hiatus popliteus? And this is something that right now is clear in my mind, something that I did not understand earlier, because for years, I used to think lateral meniscus does not attach to anything at the level of hiatus popliteus. And then I couldn't understand why you have this longitudinal tears over there. And now it's clear because it is held and attached to the fibula from behind. And we used to suture the lateral meniscus at the level of hiatus popliteus all inside, meniscus with the meniscus. And I believe it's important also to reattach this ligament there. But it's not the only structure that holds meniscus there. I mean, menisco-popliteal fascicles, superior and inferior, also have a great importance.
Yeah, it's a complex attachment on the lateral side, maybe more complex than on the medial side. But do you think you can repair it like maybe a ramp lesion on the medial side with a suture hook, or how do you do it in surgery?
This is how I try to do it. And I think that one can understand better what's the importance of this ligament if you observe patients with discoid meniscus. We usually, if somebody decides to operate on discoid meniscus, we cut off, recut the shape of the lateral meniscus, but many patients will still have some clicking in the joint. And this is because very often they have congenital absence of those ligaments that holds the meniscus in the back. So whenever you flex and extend the knee, the meniscofemoral ligaments will pull the meniscus into the joint and nothing holds her back. And this is why this clicking comes from. And actually, I don't have a solution for that, because if there's something that was injured and you kind of suture it, and I think the comparison to ramp lesions is very good because you don't have any strict ligament, you have a bunch of soft tissues over there, so you are hoping for a good scarring, I guess. But if you have an absence of these ligaments, what to do, how to hold this meniscus back so we have the proper biomechanics of the meniscus.
Yeah, thank you, Ursula, also from my side for this great video. Maybe one additional clinical question from my side. in case of chronic ruptures or chronic conditions, do you can distinguish these patients clinically from those with an isolated meniscus body tear on the lateral side, or do they just present with lateral meniscus pain, which is not really specific for this condition?
I couldn't define any specific symptoms of this particular ligament to be injured, but I had patients with the posterior lateral pain. We do the MRI. Sometimes if the core of the meniscus is fine, we cannot see anything, and then those radial sequences are really useful. Sometimes I even inject them with some type of contrast or even the saline, and then you can see it much better, especially after big trauma. Everything is, connected to everything, so it's not that easy to diagnose that.
Okay, so thank you, Urszula, from our side also for the video submission, but also for your personal attendance and the worthwhile discussion. Now it's time to vote on your video.